Welcome to The Explainer. Today, we're diving into a really fascinating electrical problem in the heart, where signals can get delayed or even completely stopped in their tracks. We're talking about something called an atrioventricular block, or just AV block for short. We're going to break down exactly what that means and, more importantly, how you can learn to spot it. Okay, let's kick things off with a simple way to think about this. Imagine your heart's electrical system is a super busy highway. The electrical signals are the cars zipping along, keeping the whole operation running smoothly. But what happens when those cars get stuck in a major traffic jam? Well, that's pretty much what an AV block is, a traffic jam in heart's own wiring. So here's what we've got on tap. We'll start by looking at the normal flow of traffic. Then we'll get into the different types of jams. After that, we'll learn how to read the road signs on an ECG, play detective and look at the causes, and finally figure out how to, clear the road. All right, first things first. Before we can even begin to understand a traffic jam, we've got to understand what a normal day on this highway looks like. So let's take a look at the heart's normal conduction pathway. So it all kicks off at the SA node, which is the heart's own natural pacemaker. That signal shoots out and makes the atria, those are the top two chambers, give a good squeeze. Then, and this is super important, it hits a little pause at the AV node. Think of it like a gatekeeper, holding the signal just long enough to let the ventricles, the bottom chambers, fill up with blood. Finally, the signal rockets down the super-fast network of fibers called the His-Purkinje system and tells the powerful ventricles to pump. The whole thing is like a perfectly choreographed dance. Right, so that's how it's supposed to work. Smooth, efficient, perfectly timed. But what happens when we get a roadblock on this highway? Well, that's where AV blocks come into the picture. So the official textbook definition is an atrioventricular conduction disorder. It's when that electrical signal coming from the atria gets either slowed way down or just completely stopped on its way to the ventricles. At its core, it's just a communication breakdown. The top of the heart and the bottom of the heart aren't talking to each other properly. Now, we can slice and dice these blocks in two main ways. First, we look at the severity, or what we call the degree. Is it just a little slowdown or a total gridlock? Second, and this is really crucial for doctors, we classify them by location. Is the traffic jam happening at the AV node? That's usually more stable. Or is it happening below the node, in what we call the infrahisian system? A jam down there is way more dangerous because the backup systems just aren't as reliable. Things can go south fast. All right, time for the fun part. How do we actually spot these traffic jams in the wild? The answer is the ECG, the electrocardiogram. It's like our set of traffic cameras for the heart's highway, and it gives us all the road signs we need. Okay, first up, first-degree AV block. On the ECG, that first little bump is the P wave. That's the atria squeezing. The big spike that follows is the QRS complex. That's the ventricles. And that gap, the time it takes for the signal to get from the P wave to the QRS, that's what we call the PR interval. Now with this block, that PR interval is always a little too long. We're talking over 200 milliseconds. But, and here's the key, it's always the same length. Every single P wave gets a QRS. It's slow, but it's steady. Okay, moving on to second-degree Mobitz type 1. You might also hear this called a wink block. Watch that PR interval again. Beat 1, it's kind of long. Beat 2, even longer. Beat 3, longer still. And then, poof, you get a P wave with no QRS after it. That signal just didn't make it through. It's the classic going, going, gone pattern. And then the whole cycle just starts over. Now, this is a big one. Mobitz type 2. And you need to pay close attention because this one is much more dangerous. The PR interval here is constant. It looks perfectly fine from one beat to the next. But then, bam, out of absolutely nowhere, a P wave shows up all by itself with no QRS to follow. A beat is just dropped without any warning. And the reason we get so concerned about this is because the problem is usually way down in that fast electrical highway where the backup systems are shaky. This thing can suddenly turn into a complete block. So let's put these two head-to-head because this is a really important distinction. Mobitz I, usually at the AV node, that PR interval gets longer and longer and the risk is pretty low. Mobitz 2, that's down in the His-Purkinje system. The PR is constant until it drops, and the risk of it getting worse is high. The analogies say it all, right? One's a predictable traffic jam, the other is a drawbridge just slamming shut in your face. And that brings us to the big one, third degree or complete AV block. The highway is completely washed out. There's no getting through. Look closely. You see the P waves? They're just marching along at their own pace, doing their own thing. The atria are totally on their own schedule. And then you see the QRS complexes, the ventricles. and they're beating at their own slow, steady pace. They're completely independent. This is what we call AV dissociation. The top and bottom are divorced. And this is a true medical emergency because that ventricular rate can get dangerously slow. Okay, so why have we spent all this time telling these patterns apart? Well, it's because it completely changes what we do for the patient. If you see a first degree or a Mobitz 1, you're usually not too worried. You'll monitor them, but it's low risk. But the second you spot a Mobitz 2 or a third degree block, that's a whole different ballgame. These are unstable, high-risk situations that almost always mean the patient needs a permanent pacemaker to keep their heart beating safely. All right, so we know how to spot the different kinds of jams. Now let's put on our detective hats. What's actually causing them? And what would a person with one of these blocks even feel? So when the block makes the heart rate drop too low, we call that bradycardia. The body just isn't getting enough blood. And that's what causes all these classic symptoms. Feeling dizzy, actually fainting, being tired all the time, or getting short of breath. But here's a really key point. A lot of people, especially with the lower grade blocks, feel totally normal. They're completely asymptomatic. When we look for causes, they usually fall into one of two big buckets. First, you have intrinsic causes. This means the problem is in the heart itself. Think of things like scarring from just getting older, which we call fibrosis, or damage from a heart attack. Then you've got extrinsic causes, stuff from outside the heart that's affecting it. This could be medications like beta blockers, or even something called high vagal tone, which you sometimes see in really high-level athletes, where their nervous system just keeps their heart rate super low. Okay, so you've got a patient, they've got some of these symptoms, and you see a block on the ECG. What's next? How do we nail down the diagnosis and figure out the best treatment plan to clear the road? The workup here is really systematic. You don't just jump to conclusions. You always start by talking to the patient and doing a physical exam. The 12-lead ECG is your main tool. And if you suspect a block but it's not showing up right now, you might send them home with a monitor, like a Holter, to wear for a day or two to try and catch it in the act. And this is so important. We always hunt for a cause we can fix, using blood tests and heart imaging. All right, when it comes to treatment, you basically come to a big fork in the road. And the very first question you have to ask is, can I fix what's causing this? If it's a medication, you stop it. If it's an infection, like Lyme disease, you treat it. You get the idea. But if the cause is something permanent, like scarring, and the block is one of those high-risk types, a Mobitz 2 or a third degree, well then you're almost always talking about a permanent pacemaker. So let's get really specific. Who actually gets a pacemaker? The guidelines are pretty black and white on this. Pretty much anyone with a Mobitz 2 or a third degree block is going to be offered one, even if they feel fine. Why? Because the risk of something bad happening suddenly is just too high. But on the flip side, if you have a first-degree block or a Mobitz I and you feel totally fine, you almost certainly do not need a pacemaker. It's all about that risk-benefit calculation.
So, to put a bow on all of this, we've really gone on a journey here, right? All the way from a simple delay to those going, gone blocks, to the sudden, unpredictable ones, and finally to a complete electrical divorce between the heart's chambers.
So if you remember nothing else, remember these 4 patterns. First degree is just a long PR. Mobitz I is longer, drop. Mobitz 2 is a constant PR and then a sudden drop. And third degree, total chaos. Ps and QRSs are completely independent. And the absolute golden rule, the lower down the block is in the heart's wiring, the more worried you should be. Location determines risk. And that brings us to one last thing to chew on. I mean, think about it. So many of us have smartwatches and gadgets that are tracking our heart rhythms all day, every day. As we start picking up more and more of these so-called low-risk blocks in people who feel perfectly fine, how is that going to change how we manage them in the future? It's a really interesting question. Thanks for joining this explainer.